A very good afternoon to you all. We appreciate the opportunity to share with you our experiences of using the critical path to support rapid expansion and optimization of a national PMTCT program in Zimbabwe towards the elimination of new HIV infections. And this having been implemented between 2011 and 2015. So this is the outline of our presentation, and a few disclaimers up front. Primarily the fact that this is not based on research, but on implementation experiences. So we begin by sharing data on selected maternal and child health indicators around the period 2010, which was just about the time that we started implementing this program, with annual expected pregnancies at just over 400,000, HIV prevalence in antenatal care at about 16%, and mother-to-child transmission rate at about 18%. So in terms of background to the use of the critical path, the Elizabeth Glaser Pediatric AIDS Foundation received funding from the Children's Investment Fund Foundation in 2011. The aim of this grant being to support the Ministry of Health and Child Care to roll out the WHO 2010 guidelines to all maternal and neonatal child health facilities, optimizing the effectiveness of the PMTCT program in the process, and also to reduce mother-to-child transmission of HIV from about 18% in 2009, as mentioned earlier, to less than 12% by 2015. So we needed a strong program performance management tool in order to achieve this ambitious goal, and hence the critical path. So the question is, what is the critical path? And for some, we may know the critical path from literature around project management and the private sector, particularly the construction industry. But in our case, the critical path constituted a prioritized set of performance indicators and targets for those indicators, which were aimed at driving the reduction of mother-to-child transmission per the goal of the program. I'm glad to be talking about it at this time that we now have the UNAIDS 90-90-90 targets. So the concept of the critical path is quite synonymous with that. You have specific indicators which also have specific targets, which when you achieve them over a time frame, you will be able to achieve the goal of your interventions. So the use of the critical path also involved data-driven program reviews, which were conducted on quarterly basis. And during those program reviews, each indicator would be reviewed, comparing the performance of the indicator against the targets for that indicator. And then where an indicator would not have performed well to achieve the targets, you would have discussions around possible reasons for non-achievement of the targets, and then identify solutions which would then be implemented in all the health facilities that we were supporting during site support. And our main vehicle for delivering this support to the health facilities was through a cadre that we termed a district focal person, who was recruited by EGPAF and seconded to the Ministry of Health and Child Care at district level to support implementation of the PMTCT program at district level as well as health facility level. We have shared this model in the International AIDS Society Conference of the previous years. In addition to that, the funding of the program was modeled innovatively in such a manner that program activities would be planned annually, and the budgets would also be reviewed annually to make sure that what was invested in the program in terms of activities and in terms of allocation of resources would be guided by the critical path. So resources and activities would have to be going towards the areas that would be lagging behind in performance on the critical path. So in this slide, we share a graphical representation of the critical path. So as mentioned earlier, the critical path would have selected indicators, prioritized indicators from both the maternal and infant cascade of the PMTCT program. Each indicator would have a target, an annual target, which was actually population-based. And then during every quarter, the critical path would be populated with performance data for the quarter. And then in the reviews that I mentioned earlier on, we would then compare the performance of each indicator with the set target, and then discuss any challenges experienced and propose solutions as explained earlier. I mentioned also that in the process of those discussions during program reviews, some solutions would be suggested to any indicators that would not be performing well. So we would term such solutions course corrections. And in this slide, we are sharing an example of such course corrections, specifically on one indicator, which was HIV testing for pregnant women, where in one quarter, we realized that the indicator was performing below target among a number of reasons, primarily due to the fact that a new HIV testing algorithm had just been introduced in the national program, and concomitant to that was a delay in supply of new HIV test kits. And so the solutions recommended and implemented included EGPAF supporting on-job training for healthcare workers on the new algorithm, as well as supporting the movement of the test kits as they became available to health facilities, and this being done during site support through the district focal persons. So looking at some of the achievements that were then realized in the program over the 5-year period, part of the goal being to rapidly roll out the WHO 2010 guidelines and later on the 2013 guidelines. We saw that sites offering comprehensive PMTCT services, and in this case HIV testing and ARVs on site, they increased rapidly in 2011, which was the first year of implementation. We also realized that during the rollout of the WHO 2010 guidelines and the 2013 guidelines, we actually managed to complete the rollout in a much shorter time period than ever before, in less than 12 months to be specific in both instances. And looking at trends in the critical path indicators over the 5-year implementation period, we realized that all the critical path indicators had marked improvement over the 5 years. And this included the indicator on retention of mothers on antiretroviral therapy, which we started tracking in 2012 as part of course corrections in the program, when we started implementing an electronic patient monitoring system in selected health facilities across the country. And I put a note here that this electronic system was not designed to be linked from facility to facility, so it would simply track retention of the women at specific health facilities. We have had an opportunity for some population-based surveys that were implemented in around the same time that we were implementing our program. So when we look at key maternal child health indicators from the demographic and health survey of 2011, 2010-2011, which is about the time that we started the program, and then data from the multiple indicator cluster survey, which was implemented in 2014. Again, we see that all key maternal and child health indicators have improved quite a lot in Zimbabwe. And specifically, the mother-to-child transmission rate has declined from about 18% in 2009, as mentioned earlier on, to 6.7%, according to the population-based survey that has just been implemented by the University of California, Berkeley and partners, and has already been presented in this conference elsewhere. So our conclusions from this experience are that the critical path was an effective tool for program performance management and achievement of the ambitious goal that we were working towards. EGPAF and CIF assisted the Ministry of Health and Child Care to achieve the goal of rapid scaling up and optimization of PMTCT services and reduction of mother-to-child transmission rate below 12%. The MTCT rate is now close to the Ministry of Health and Child Care's elimination goal of less than 5% mother-to-child transmission rate. As of now, EGPAF and CIF are now implementing a new set of critical path indicators which are focusing on improving quality of PMTCT services and children's at cascade. So we believe that with the science increasingly becoming available, resources also being available, and good program management tools like the critical path, we certainly can win the war against AIDS, and in our case, until no child has AIDS. We would like to acknowledge the Ministry of Health and Child Care in Zimbabwe for their commitment towards the goal of eliminating new infections in children and keeping mothers alive, and also the strong program leadership and coordination in the country. The Children's Investment Fund Foundation for funding the program, especially in an innovative way that allowed tailoring program activities and budgets annually to respond to the gaps in the critical path cascade towards the intended goal. We also appreciate the contributions of our partners in this program that we named the Family AIDS Initiative, the patients and their communities, other Ministry of Health and Child Care partners who contributed to the national results that we have shared in this presentation, and the co-authors to this abstract, and you particularly for listening to this presentation. Thank you very much.
Thank you, Ruben.